Welcome everyone to today's webinar. I am Emma Goodman with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are thrilled to have Scott Becker, publisher of Becker's Healthcare, here to moderate the Q&A session today. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Dr. Joe Tobin obtained his medical degree from SUNY Upstate Medical Center in 1983. He completed residencies in pediatrics and anesthesiology. He completed a fellowship in pediatric anesthesia and critical care in 1990, where he joined the faculty at Johns Hopkins. In 1993, he and his wife were recruited to the Wake Forest University School of Medicine. He was promoted to the rank of professor with tenure, and in 2008, he became the chairman of the Department of Anesthesiology until 2014. He has published extensively in basic and clinical science areas. He has been an advisory committee member to the FDA, president of the Society for Pediatric Anesthesia, and he currently is a member of the board of directors of the Malignant Hyperthemia and Association of the United States. He consults to both medical technology and pharmaceutical firms related to anesthesiology and critical care. Dr. Tobin, it's now my pleasure to turn the floor over to you to start the presentation.
Thank you, Emma, and thanks to all of our attendees. We're very appreciative of your interest in today's subject. Throughout the presentation, you will find a number of abbreviations, and I will attempt to identify them at the first time that we see one on each slide. And we're going to cover two subjects today. The first will be the risk of postoperative delirium, and then secondly, the risk of postoperative cognitive dysfunction. And first, we'll define those. We'll talk about the epidemiologic impact, the financial impact, and then the therapeutic opportunity available to reduce the incidence of postoperative delirium and POCD. So we will define both of these terms. We'll describe the impact on patient outcomes, the economic implications, and how to potentially provide a strategy to educate staff and increase the awareness of both of these comorbid conditions should they occur following anesthesia, and then put a summary together. So postoperative delirium is an acute change in cognition characterized usually by inattention, an altered level of consciousness, or disorganized thinking. And as an anesthesiologist for 25 years, the thing I most concern myself with is when it's hyperactive, so that as a patient is emerging from anesthesia, they can sometimes be hyperactive both on the operating table as well as during the transport to the recovery room. During this time, there is risk to both the healthcare providers as well as to the patient's safety because the patient cannot be rationally dealt with and often has to be subdued until we can get into a secure space. The etiology was once felt to be exclusively the realm of anesthesia, whether it was due to hypotension, residual anesthetic effects, or other impairments that we may have induced. But it's now been recognized that it's more than just anesthesia related. It has to do specifically with the aging population, the possibility of electrolyte abnormalities, and now we've begun to understand that there are surgical inflammatory factors caused by the trauma of surgery that can affect the central nervous system. The most concerning part of this presentation has to do with the fact that we have an aging population. And the aging population is responsible for an increasing percentage of surgical and anesthetic management, and therefore the epidemiologic manifestations of POD and POCD are exacerbated with our aging population. Also, the physical function of the patient prior to anesthesia and surgery and or the length of the surgery may be involved. I am switching to another phone due to a low battery signal here.
Thanks, Dr. Tobin, and it'll just be one more minute before we resume the presentation.
Great, thanks so much. Just want to be sure I didn't lose everyone. Now, on this slide, we define a few common operations among our elderly population. The first is the coronary artery bypass grafting. The next is aortic aneurysm surgery. Third is hip fracture. And then finally, for control, we have a slide graph of elective orthopedic procedures. Now, the acute changes that occur and the long-term implications of both POD and POCD can be seen by both the light blue and then the darker blue percentages. So the acute changes that occur with some of these major operations can be in 50 to 65% of the entire population by the time they've been received either into the ICU or into the recovery room. The lower percentages represented by the light blue are those changes that have long-term implications, including postoperative cognitive dysfunction at a week or later after the elective surgery has been completed. So in a substantial number of these patients, we still have long-term residual issues that can complicate both the length of stay, hospital-acquired conditions, the determination of where the patient can be safely discharged to, which may have to include skilled nursing facilities. And if we take a look at the lowest bar, the elective orthopedic procedures, you see that when we have, other than hip fracture as a major surgery, the other orthopedic procedures do not have nearly as common a postoperative problem as do the more major surgeries shown above. Now, postoperative delirium is most common on post-op day 1 and 2. And in fact, it can last only a few hours, but usually by the time the patient has been received in the ICU, they may have been administered a greater number of sedatives just to be able to keep them in the bed. The patients are not interacting appropriately with their environment, and the violent actions, although not common, can certainly be most difficult for risk management and employee safety. The postoperative delirium is considered exclusive of no problem with the CNS with infection or with drug withdrawal. And so this is brand new, and it's occurred as a result of both the surgical procedure and the anesthetic management. About half of these patients will have resolution within the first 2 days, but still a third of these patients have symptoms at discharge, and a half of those will still experience symptoms at 1 month post-discharge. So if someone was prior to anesthesia and surgery able to barely meet with their activities of daily living, we now have a substantial increase in the percentage of patients who may not be able to fulfill those needs and need skilled or some other assisted care. We can identify some risk factors for postoperative delirium during a preoperative visit. And the one that really has the most concerns for us are the patient population age 70 and greater, and those with a physical function that are impaired. We also know that if there are electrolyte abnormalities preoperatively and or if there's a known history of alcohol abuse, this may add to the problem of postoperative delirium. Now, the complications from the delirium include, as a direct result, an increased length of stay with an estimate of somewhere between $2,000 and possibly $2,500 cost per day. There's an increased need of ICU utilization and or ICU readmission when the patient is not able to be stabilized and allowed to go to the lower level of care. We've seen patient falls and injuries because of a lack of coordination. We've seen employee injuries. And then now, as of October 1st, we now have an increasing Medicare penalty for readmission, the new penalty being upwards of 3% of Medicare reimbursement. And then finally, as we've seen in our institution, higher rates of discharge to nursing homes, which are attendant with increasing lengths of stay because of having to identify a facility which can and will accept the patient in this impaired state. And although most members of the C-suite will understand the approximate costs involved, the nursing home expenses for each person who requires long-term care after an acute hospitalization is approximately $75,000 per person. On the lower half of the slide from the U.S. Census Bureau, I've given estimates of the age of the population and the number of patients that are in that population age. If you take a look below, the last line says 65 plus years in age in a skilled nursing facility in 2010 was 1.25 million of 40.2 million in the population ages 65 and up. That is an estimated cost of approximately $94 billion a year. Now, there are programs that can provide interventional help in order to help reduce the risk of postoperative delirium. So many of you already have instituted some of these interventions, including orientation, improved natural sunlight exposure for the patients. We in anesthesia are guilty of not allowing patients to have their glasses or hearing aids back at a very early time because we're afraid of the potential loss of those. Early mobilization is certainly now occurring even in ICU patients who may remain intubated and ventilated. We have better control and pain management opportunities available, but one of our problems is that we try to minimize polypharmacy and in particular opioid medications to try to reduce the CNS sedative effects. We still see fluid and electrolyte management disorders. Most particularly, we worry about hyponatremia and or hypoglycemia. And finally, what we've also been trying to do is in our anesthetic management, we've been trying not to overdose the amount of anesthesia that the patient requires in order to prevent awareness under anesthesia. However, when we do use an appropriate amount of anesthetic and don't have the patient too deeply anesthetized, we run the risk that the patient may move, and that could be a problem during certain types of surgery. And if the patient is too deep, they may have a longer recovery period, and that would include a time where postoperative delirium is at a higher prevalence. We also have a balanced view about using supplemental oxygen and transfusions because we understand the risks of using supplemental oxygen in the elderly population, as well as in the potential issues associated with transfusion therapy. So the point of this seminar today is really, is there something we can do to decrease or lessen the prevalence of postoperative delirium? And what we have found is that by monitoring the depth of anesthesia in randomized trials, we can reduce the rate of postoperative delirium, but the rationale by which this would then decrease postoperative cognitive dysfunction is correlated, but it hasn't reached statistical significance. And to date, there have been many thousands of patients studied, but not hundreds of thousands. Medtronic provides a device called the Bispectral Index Monitoring System, which is a proprietary system that evaluates the EEG while a patient is anesthetized. And by displaying a value between 0 and 100, we can have an understanding of about approximately how deep the patient actually is under anesthesia. Now, we know that as patients age, they sometimes need less anesthesia, but we also are acutely aware that in young patients, if we use only a standard dose of anesthesia, the risk of awareness does exist. And the BIS monitor is available to the anesthesiologist and the anesthesia care team to prevent a patient from either being too deep or too light during anesthesia. It's easy to apply, and we use it in selected populations who are at risk for postoperative delirium, and also patients who've had a history that they may have had awareness under anesthesia in the past, and we want to absolutely prevent that if possible. Now, in the next half dozen or so slides, we'll see a number of graphs that will include the prevalence of postoperative delirium following different types of anesthesia. And this will include both with a light and a deep BIS number being allowed. And then also we will take a look at BIS-guided anesthetic levels versus end-tidal anesthetic concentrations. And the reason that this is important is if an anesthesiology team can decide that this patient would do better in a certain BIS range, then as we titrate the anesthetic to that level, we really do believe we can give the patient the smoothest perioperative course and reduce the risk of postoperative delirium. So in the study shown here, this is a prospective randomized double-blind trial of patients over 65 years of age for a hip fracture. They were screened out for no preoperative delirium, and in the protocol, the patients who were going to have a spinal anesthetic, here noted as SAB for subarachnoid block, they were allowed to have a maximum of 2 milligrams of midazolam for their sedation for the block to be placed. Then, during the operation, most surgeons don't want patients asking questions, so we still titrate with the drug propofol to try to keep the patient mildly or more significantly sedated. And so the deeper target was a BIS number of 50, or the lighter target was a BIS number greater than or equal to 80. And then the patients were assessed with a standard exam following this. So the incidence of delirium in the deep BIS group was 40%, and in the light BIS group, it was 19%, which was statistically significant and equals a 53% reduction in the incidence of delirium using this type of study. This is by Dr. Fritz Sieber and his colleagues, and it was published in the Mayo Clinic Proceedings in 2010. So also during spinal anesthesia, the other findings included more days of delirium per patient in the deep group. And for those with delirium, the length wasn't very different. But in order to try and reduce the incidence of delirium, if each patient is assessed with the BIS monitoring probe, 5 probes, $100, and the NNT is number needed to treat in order to have a benefit to a patient in the trial. And the number needed to treat is 4.7 patients. So if we estimate the cost for 5 BIS probes would be $500, but the cost of 1 case of delirium would be $2,500 or more for just 1 day extended length of stay, we see the economic opportunity that may be in front of us. Also, in this slide, is delirium predictive of postoperative cognitive dysfunction? Well, it may be predictive, but it's not statistically significant in all studies. So in this circumstance, although we can have faster emergence and a shorter recovery room stay, and in this case it found fewer infections, there was a reduction of 35% of the incidence of delirium, which was significant, but for postoperative cognitive dysfunction, it was at a level of about 0.058, which was not quite statistically significant. Now, if any of us in the clinical area or in the C-suite are contemplating knee or hip surgery or other major surgery, depending on the type of surgery that needs to be done, we may be offered regional versus general anesthesia. Now, during regional anesthesia, which means with blocks of different nerves throughout the body or a spinal or an epidural block, it is still routine that the patient will be sedated so that they do not complicate the situation by conversing with the surgeon. Some patients refuse regional anesthesia, or it's contraindicated because they're on an anticoagulant, and then the patient will have to have general anesthesia for the same type of operation. Now, in the 2004 Cochrane review, it showed that regional anesthesia was associated with a reduced risk of acute postoperative confusion compared to general. But later a meta-analysis by Mason demonstrated that regional anesthesia was no benefit over general anesthesia for delirium. And this brought into question what is the standard sedation that's used in most regional anesthetics. And without having controlled it or monitored it with the BIS monitor, we find that we are probably overdosing our patients just to try and keep them quiet and not interfering with the surgeon. So during sedation, for these patients over 65 years of age who receive spinal plus propofol sedation, their BIS value was greater than 60 almost 70% of the time. That also shows that we had 30% of the time that their BIS monitor was under 60. And so we believe that there's a significant percentage of opportunity for improvement by reducing both the depth as well as the length of time at a deeper level of anesthesia by use of BIS monitoring and keeping the patient less sedated. So as I've said a couple times already, surgeons usually don't want patients asking questions during surgery. We do have a couple orthopedists that are willing to answer questions for their patients, but most of the time they don't want to be distracted. And patients don't want to experience postoperative delirium or nausea, which are both associated with heavier sedation or general anesthesia. So we have to find that temperate zone where we can keep the surgeon happy and keep the patient having the least number of percent complications. Now, this is a slide I referred to a little bit earlier, and this looks at the incidence of postoperative cognitive dysfunction, which is defined as cognitive dysfunction which was not present preoperatively and is now present longer than 2 days or to discharge. These two graphs show the percentage of cognitive dysfunction at both 1 week and at 3 months. So at 1 week, regardless of the BIS was used or not, the incidence of postoperative cognitive dysfunction, or POCD, was approximately the same at 21 to 23%. But the regaining of function in the patients who were BIS monitored was improved compared with the routine patients. So at 3 months, we still have POCD in about 15% of patients in the routine group and about 10% in the BIS group. As I think we get to larger population studies, we're going to see that this will have a statistical significance, but it's certainly significant for both the patients and the care providers that had the reduction, and by about a third, which certainly will help with their attribution to need a skilled nursing facility, assisted nursing, or be able to be cared for at home. So in conclusion from this study, they wrote, for every 1,000 patients undergoing major surgery, this guided anesthesia prevented 83 patients from suffering delirium during the hospital admission and 23 patients from POCD at 3 months after surgery. Now, the numbers just below are some estimates I have from a year or two ago in regards to the anesthetic volume in the United States. So we provide more than 40 million anesthetics in the U.S. annually, which would calculate out to 3.3 million cases of postoperative delirium and 920,000 cases of POCD. So if you take a look at the numbers in your institution, you could kind of use the same ratios and say, is the investment in this technology both durable as well as the per patient cost worth the potential reduction in length of stay, hospital-acquired conditions, and potential placement issues associated with the aging population? So there's a trend for less POCD, but it was not significant, still only at the 0.06 level. However, the routine care patients had more episodes of a BIS less than 20 and a higher average suppression of their EEG. So that suggests that we are heavy-handed with our anesthetic technique when we don't have a monitor to help guide us to use less because we're putting the patient into a deeper state than is actually necessary. Now, in a group of patients that were studied for postoperative delirium, this was in a sub-study of cardiothoracic surgery patients in the BIS-associated guided recall clinical trial. So this was 310 patients who underwent cardiac or thoracic surgery and were going to the ICU post-op. The BIS group was to titrate the BIS monitor to less than 60, and then the ETAC group was to keep the end-tidal anesthetic concentration at 0.7 to 1.3 of what we call MAC, the concentration we believe is necessary to cause unconsciousness. But then they were without the BIS guided therapy. So the delirium assessments were then looked at in the ICU and at discharge, or 10 days, whichever came first. And if we take a look at the end-tidal anesthesia concentration, the incidence of delirium was 28%, but in the BIS guided group, it was 18.8%, again, a 30+% reduction, suggesting again that we, without the use of this monitor, are slightly heavy-handed with our use of anesthetic agents. This slide is just a number of studies which I've provided for your reference for later, and that is that there are multiple studies which now suggest that the ability to both monitor and provide an appropriate reference range will be beneficial to reduce post-op delirium and probably POCD, particularly in the at-risk population, being the aged population. Now, one of the issues that we have is that how do you educate an entire staff, including a group of anesthesiologists, CRNAs, anesthesia residents, and surgeons, that they need to be aware that there is an increased issue with POD and POCD in this at-risk population. So we can focus this issue at both surgical and anesthesia grand rounds, and that'll educate both the surgeons and the anesthesiologists to be aware of this complication. We still need an intervention to be able to reduce it. Now, it is expected that once the surgeons are aware that this is a problem, that they will allow or cooperate with the anesthesia team to formulate a plan which would reduce the use of anesthetics and use a BIS-guided anesthesia administration to reduce the POD. And from a leadership or a C-suite perspective, we need to make sure that we recognize that it will require leadership to negotiate these sometimes difficult behaviors, but there's significant health benefits, savings, and employee benefits with hopefully dealing with less violent or at-risk patients, both in the recovery room and in the ICU. Anesthesia leadership sometimes has difficulty being able to provide a ubiquitous behavior across a certain domain because of either documentation issues or clinical issues, but regardless, they will require the assistance of senior leadership in order to be able to bring about the more consistent use of a monitor, which could have significant improvement in both patient care and in cost savings. And it is also a commitment from senior leadership that the technology has been evaluated and vetted, and that it can be appropriately used for a high-risk group, and that the resources required to purchase this and utilize it will be provided. So in our own institution, I've just provided a short example. We were running a cost of a little more than $500,000 a year in our volatile anesthetic agents. We identified that, and we thought there was a cost reduction initiative that we could take. So we educated all anesthesia providers to use what are called low flow rates after the induction of anesthesia. And if they were willing to do that, we would not eliminate the most expensive volatile anesthetic, which is what some people really wanted for the shortest cases. All anesthesia providers were involved. And now as we look back and look at the economic influence over a 5-year period, we've had an annual 50 to 60% cost reduction from an annual expense of $550,000 to $240,000 sustained for these 40,000 anesthetics per year. The leadership commitment is essential, but the chair of anesthesia will not be able to do it alone. It will require C-suite support to be able to bring apart this kind of a cost change and improvement. So I hope I've introduced today to those who've not heard the terms before, postoperative delirium and postoperative cognitive dysfunction. This may seem odd coming from a person who's really a pediatric anesthesiologist, but my research training at Johns Hopkins had to do a great deal with cerebral blood flow and cerebral recovery after anesthesia. And so we've been very watchful of the development in the BIS trials and publications that have come out over the last 10 plus years. We're more acutely aware at higher levels of the organization that we need to reduce the length of stay, hospital-acquired conditions, and readmissions. And the Medicare penalties are going to make that be ours to handle cost-wise if we don't do it. There are probably now, I'm guessing, closer to 50 to 60 million anesthetics in the U.S. this year. But I would say that much of that is because of elective colonoscopy. And so those procedures, which are rather short and do not require the depth of anesthesia that these more involved surgical procedures do, are not listed here as being a high-risk group. But possibly the over age 70 group may be. We certainly know that the percent of the population that is aging and requiring more procedures continues to advance. And now we understand a little bit better some of the contributors to postoperative outcomes. But it's not very easy for us to intervene in a quick sweep to reduce surgical inflammatory factors, even though we can now at least monitor the depth of anesthesia and we can titrate the anesthetic appropriately for that. So BIS is a technology which not only is approved for monitoring anesthetic depth and reducing the anesthesia dosing, but it also reduces the risk of inadequate anesthesia or awareness under anesthesia when we might be using a paralyzing drug as well. So we find the technology to be useful in both of those domains, and some are for the elderly, which is to reduce the anesthetic dosing, and some are for the younger or those that have had a previous episode of awareness under anesthesia. Postoperative delirium occurs at a high incidence, especially in the elderly, and many of us probably have heard some family members say at one time, Grandpa was never the same again after his hip surgery. We now know some of those risk factors and precipitating factors, and we think that we can attack the anesthetic management utilizing this effective monitoring system. I want to thank everyone who's come on the call for your interest in leading and promoting patient safety, and we certainly have time available for question and answers as well. Emma and Scott, I'll bring it back to you.
Thank you so much. Emma, do you want to explain how people can ask questions and then, or enter in questions? And then Dr. Tobin, I've got a handful of questions that have come up so far. Emma, can I give you one moment to just tell the audience?
Absolutely. So we will be now beginning the Q&A portion of the webinar, and you can type in any questions that you have into your control panel in the space labeled "Enter a question for staff" and then clicking send. So Scott, I'll turn the floor over to you.
Thank you very much. Dr. Tobin, let me start with questions may asked by the audience. Is there anything a patient can do to reduce the risk of postoperative delirium?
Well, there are early studies which are suggested there might be, Scott. So we are now asking patients that have inadequate nutritional reserves prior to their elective anesthetic to obtain those reserves and a mild exercise regimen in the first 7 to 30 days before an elective procedure. Certainly, we also try to get patients to interrupt a pattern of smoking for upwards of 30 days prior to the procedure as well, which may lead to less risk on a microcirculatory basis of vasoconstriction or perioperative stroke. In regards to delirium, it's maybe a little bit of a stretch, but we certainly know that if someone has low albumin ahead of time, their risk of any complication following elective anesthesia is higher. So we focus on nutritional counseling and a mild exercise program ahead of time. Those have yet to be borne out completely to reduce the risk of postoperative delirium. And then secondly, we need a better tool to assess patients' alcohol consumption. If we knew that, we would be able to better titrate and understand the dose of anesthetic drugs that might be necessary to prevent awareness. But certainly the BIS monitor seems to help us somewhat with that.
Gotcha. So 4 or 5 things that can help, and then the BIS monitor helps as well. It is critical as well. There's a question here. It's from one of our members of the audience, and it says, we had a 25-year-old who had postoperative delirium. For that patient, is the key reduced anesthetics, or what's the key to dealing with a younger patient who has experienced postop delirium before?
That is a great question, and not a very simple one to answer. If a patient comes to the anesthesia team and says, I have had postoperative delirium and I really don't want to get through that again, it offers the team an opportunity to consider a different type of anesthetic combination. So instead of using the volatile anesthetics, unless they became necessary as part of the gases that you breathe, we would consider using an intravenous anesthetic that would include both propofol and possibly the drug dexmedetomidine, which is a milder sedative, but it would allow us to reduce the total dose of propofol. And that usually allows the patient to awaken more quickly, including having their frontal lobe begin to work, which is probably where the disinhibition is happening because there's residual anesthetic in the frontal lobe and the person can't bring themselves back under control, and hence they're delirious. So with the addition of appropriate analgesia, a lighter and a different type of acting hypnotic, being dexmedetomidine, we think that if we had that history ahead of time, there would be possibility that both with this monitoring and with pharmacologic management, we could reduce that risk. We can't take it away to zero, but we also know that we have to control pain. So we have to be judicious with our use of opioids and certainly don't have the patient wake up in writhing pain.
Gotcha. Let me ask you another question. And it relates to, have you seen research on postoperative delirium in fracture patients, hip fracture patients, where they had regional blocks, such as the adductor canal block, in addition to a propofol drip?
Yes, we still see it in that group as well. So, there was a time where we thought that any CNS manifestation that occurred during hip surgery had to do with emboli that were caused physically by the actual surgery itself, or fat emboli that were released from the marrow of the bone. We know that that is not completely the answer, and that much of this may have to do with the anesthetic management and the drugs and the residual effects that we still see in patients.
Another question somebody had is, can the Medtronic BIS be integrated with Epic EMR? Hasn't been done yet. Is that being done? Can it work with the different EMR systems out there, particularly Epic, and much of that's in your wheelhouse?
I would have to say I think it is compatible. I'm not the technical person to know how to actually have that done, but Medtronic Covidien could certainly tell us if that capability exists. I believe that on our own Epic record in the last year that I was working clinically there, that I thought that we were transferring the BIS information over, but I may be mistaken in that matter.
How long have you been using the BIS, or working with the Medtronic BIS, and could you talk just a bit about some of your experience with it, as long as maybe on the phone?
Sure. So at Wake Forest University, we've had BIS monitoring available to us for more than 10 years. We have it available for every room, both outpatient and inpatient. There was a prompt increase in the utilization of BIS very early on after it was introduced. And then we found that in a select group of patients, it really probably didn't seem to matter in regards to whether we could wake them up faster, reduce the incidence of delirium. And this turned out to be probably the majority of patients that were having extraordinarily short procedures. We didn't have very specific uses for it in children, but now we're looking at the adolescent population in particular as they are having these extraordinarily long and complex procedures being done. So we've now translated using this to high-risk groups, which include any patient who's had a history of awareness in the past, regardless of where they may have had their anesthetic performed. Any patient over age 65, any patient under age 65 who has neurologic impairment, such as Parkinson's disease or some other associated illness that will put them at a higher risk for cognitive dysfunction afterwards. But it is not ubiquitously used by all anesthesiologists. So if the plan going forward is to help reduce POD and POCD across all the at-risk population, this would really take a leadership commitment to say we're going to do this as a part of our guidelines or our standards of care for all high-risk patients. We had not obtained that yet, but we've been very pleased with those patients that we've used it to both prevent awareness under anesthesia as well as to have the best post-operative course that we think we can provide. It has been quite useful to us.
Gotcha. I've got a couple questions here on, are you using a standardized screening tool preoperatively to identify potential or previous episodes of delirium?
It's only as a standard question. Was there, and so I must admit that our screening tool is not very robust. It includes specifically asking the patient or the patient surrogate who may be with them, were there any previous anesthetic or perioperative problems? And then most people, the most common complaint we will get will be nausea and or vomiting. And we don't know that that's necessarily as well related to the depth of anesthetic as it probably is to the dose of opioid that was used in anticipation of control of pain. But after nausea, vomiting, then people do talk about, well, yeah, Dad was a little delirious for the first 6 or 8 hours in the ICU, or the nurses said he was a handful. That's the kind of questions or answers we'll get to that simple basic question, were there any perioperative problems? And if someone flat out tells us they've had a history of awareness, we rectify that right away, saying we're going to use every monitor we have possible to try and prevent that from happening for you again.
Gotcha. Let me ask you the flip side of the question, which has also been asked by one of our audience members. Do you have an evidence-based post-operative practice for older adults in your organization? So is there some sort of, we've asked, is there a standard question or protocols that's asked on the front end? Are there standard protocols identified on the back end?
It's also a great question. We don't have an organized, uniform collection system that will collect that kind of information for us. It is often based upon the anesthesiologist that was involved doing their post-operative visit to determine whether or not there have been any anesthesia-related complications. And then when patients are enrolled in clinical trials, most of us know that there is more visibility of patient complications because we have someone constantly looking for them and using a standardized tool. But across our institution, no, we don't have that. We do have early ambulation for both our cardiac surgery patients and any others that we can, and also a standardized ventilator weaning protocol, but not from the neurologic perspective. It's a great question.
What's your opinion on why some postoperative patients transgress into postoperative cognitive dysfunction versus just sort of, I guess, shorter-term postoperative delirium? Why do some go into worse or longer-term states?
Again, an excellent question. I don't think we really understand all the contributors involved about why doesn't this delirium resolve and why isn't POCD a 1% phenomenon instead of a 15% phenomenon. We could hypothesize that it has to do with the microcirculation of the brain. It could have to do with persistent inflammatory factors that are residual in some people but not in others. It may have to do with more extended periods of hypotension or deeper anesthesia while they were asleep during the anesthetic. We know that it can be polypharmacy in the plan to treat the patient postoperatively, not just with opioids, but sometimes with other CNS-acting medications, and that they may just be having a more profound effect. A particular patient that I can recall was felt to potentially have a possible subclinical seizure postoperatively after neurologic surgery, and so therefore was started on an anti-epileptic. But it was clear that this person had profound cognitive decline. This lady was in her 80s, and it was felt possibly that it was the polypharmacy or the addition of a new anti-epileptic that might be causing her to just be nearly unarousable. When the anti-epileptic was discontinued while she was still in the hospital, we saw a marked change in her in less than 48 hours, suggestive that the polypharmacy or the addition of another medication could have been the distinct etiology of why she would have appeared to have postoperative cognitive dysfunction many days to a week out.
Gotcha. And so studies, you've referenced a couple pieces of research on the prevalence of postoperative delirium. Are there more studies to support the prevalence of postoperative delirium?
There are. So the Cochrane Review from 2004 looked at a large number of studies, many of which were eliminated for insufficient controls. But although I've only mentioned about a half a dozen that I've listed in the references of this presentation, there are literally dozens, if not hundreds, of articles examining different pieces of postoperative delirium. And as I said earlier, things like preoperative nutrition, exercise and mobility, intraoperative management of the depth of anesthetic, postoperative ambulation and nutrition, and a reduction in the use of opioids while trying to use regional blockade in order to provide analgesia without any CNS-acting side effects. So yeah, there are quite a large number of studies out there for patients in all different risk groups.
Gotcha. Another question. Do you assess sleep patterns with your anesthesia consult or not typically? How often is that part of the discussion?
Do you mean for examples of sleep disorders preoperatively?
I think the concept is that the question is that some studies have shown that older adults with challenging sleep patterns may be a variable for postoperative delirium.
Again, a very interesting question. We know from the population that older adults definitely have different sleep patterns than younger adults, and that is just age-related, such that there is more disrupted sleep in the elderly population. They go through cycles where they appear to waken in between their REM cycles, and they will often self-report that they've had a disruptive or an incomplete night's sleep. And that is without any drugs being involved in regards to either trying to help them get to sleep or in perioperative drugs trying to relieve pain. The second part of my answer, I think, makes me speculate about the possibility that obstructive sleep apnea, which is an increasingly frequent diagnosis in our population, may also be contributing either by physiologic changes to multiple recurrent episodes of hypoxia or hypercarbia, or the development of pulmonary hypertension, which can occur from recurrent hypoxia, and that would be in addition to any perioperative CNS active drugs that we're using, whether it's for CNS irritability or, as we would say, QHS medicines for sleep, QHS meaning at the hour of sleep, so that hopefully they'll rest better in an otherwise noisy and uncomfortable hospital. And then we have opioids that are probably a significant contributor as well.
Gotcha. Here's probably as important a question as any. Someone's asked, Dr. Tobin, can they communicate with you afterwards about this? There's several people that have asked questions. This is one of them that's asked a couple questions, and I think probably finds it more difficult for me to translate than to be able to email with you or talk to you directly. Are you open to that, and also talking about the Medtronic BIS with people if they're interested?
Absolutely. So my email address is on the cover slide of the slide deck, so please feel free to write to me at jtobin@wakehealth.edu. And even via an email inquiry, we can set up a time to talk that's convenient for both parties.
Great. Could you just do this, just in case somebody doesn't have it there? Would you mind giving your email address just one time slowly again, just in case somebody didn't get it?
Sure. TOBIN at wakehealth.edu.
Thank you very much. There's a few more questions here, and we've had the vast majority of the audience stay on through the questions, so I'd love to keep going if it's okay.
Sure.
Dr. Tobin, one comment is, if someone's at risk for POD or seems to have POD or has had it, the thought is that that should be noted in the patient's chart and flagged for any future planned surgeries or emergent surgeries, so not solely dependent upon patient reporting. Do you want to comment on that at all? It's somewhat of a comment from an audience member. Seems like a good comment. And what's your thoughts on whether that's standard of practice?
Well, it's a very important comment, and the challenge to us is finding the right place in an electronic medical record that would be easily visible to anybody who's inquiring. And some people have suggested we should put comments like that under the allergy list, and I'm uncomfortable with that. But the idea that there is a previous comorbid diagnosis that should be made available to anybody who opens the patient's record, I think is a terrific idea. And it could be anything from previous awareness under anesthesia, previous episode of postoperative delirium. In anesthesia, we worry about patients with the somewhat rare disease, malignant hyperthermia, and there are certain drugs that we know trigger that. And yet, that's a disease that's triggered. It's not an allergy. So we still struggle with how to communicate these important pieces of medical information without just listing them under an allergy category.
Gotcha. It's trying to figure out the right place to put them so they're actually seen by the next person who works with the patient.
That's right.
Fascinating.
So, other than an anesthesia provider, if you asked any surgeon, any pediatrician, any internist to show me the anesthesia record and interpret it, they would have a very difficult time doing so because it doesn't look like any other progress note or any other page in an electronic medical record. So these are real challenges with electronic record designs, and how do we highlight these things and either put them on a first sub-page menu once the patient's medical record number has been entered. Food for thought, regardless of the vendor. Real opportunity here for us to be communicating better among all of the healthcare providers.
Great. Another question. In the slide deck, the MMSE and CAM were mentioned. Is the CAM ICU used at your facility in ICU?
Not routinely. It is used in study patients currently only, so it's not routinely. The adult ICUs, different ICUs actually use different tools based upon the fact that in one ICU it's mainly patients who are neurosurgical or neurological, and in a different ICU it's the cardiothoracic, and then a third ICU it's the trauma patients. So different tools are used by different groups based upon what they feel gives them the best indicator for their patient population.
Gotcha. We've got a couple more questions. I've got a comment from the audience that's a compliment, Dr. Tobin, about you. It says, great seminar, very informative. And I do want to thank you. These seminars are the best when they are completely not a sales pitch and highly informative. And I really thank Medtronic and yourself for that approach. This has been, I'm not a practitioner and have learned a lot myself, and our audience echoes those comments. I've had a few different comments about what a terrific webinar you've put on so far and
Great.
really
I'm humbled, and I say thank you very much.
So the next question we had was, and this is something I think you've touched in different ways on already, but maybe sort of to come back to it for some of our audience, primary risk factors in postoperative delirium. What are the primary risk factors?
Number one is age. So we would say the Medicare age distinguishing feature, 65 and older, would be probably the number one in my mind. And then the second is pre-existing neurologic condition. And I leave that very vague on purpose because it could be anything from a well-controlled seizure disorder to depression to other CNS active drugs that the patient may already currently be on. So there's a myriad of things that we will just call CNS condition, and anything that relates to that is considered a significant risk factor. And then, although I don't have the statistics on this, I think a prior episode of postoperative delirium would certainly be a modest indicator in my mind.
Let me ask you another question. Sort of, what do you see over the next couple years in sort of advancement in treatment and monitoring of postoperative delirium?
That's a great question, too. We don't have yet a robust new technology to do a compressed EEG type of monitoring. We have the best that we've got developed right now commercially available. I think that the next wave of pharmaceutical development is probably where we're going to see the next advancement. We have new agents that work via different mechanisms that may also have pharmacologic properties that they wear off extraordinarily quickly. So one of the benefits of the current drug propofol is that it has a very short half-life compared with a drug like midazolam, which is a much longer half-life, and that's perfectly fine. With the use of propofol, after we give a bolus dose, we have to continue the infusion because the half-life is so short just to keep the patient at a therapeutic concentration. Now we're beginning to see development, and these are chemistry developments and new drugs coming along the pipeline that are going to have these very short half-lives like propofol. And so although it'll be a little more complex for the anesthesia provider to have to use multiple syringe drips, for example, it may be that we will have the brain wake up much more clearly, more consistently, and have the body already cleared all the short-acting drugs that was keeping them safe and unaware during anesthesia. So I don't see technology anytime soon changing greatly, but I do see integration of the technology, as you suggest, can the BIS read over to the electronic record. And Medtronic does have a new integrated system as well that they are now beginning to market. But I think the main issue we're going to see in the next 5 to 10 years are going to be pharmaceutical development.
Let me ask you a follow-up question. Opioids is such a part of the discussion today and everything. You'd mentioned them a couple of times here in terms of impact and potential impact with postoperative delirium. Can you just explain, for someone who's not as educated, how opioids all impact this and decisions on anesthetics and so forth?
Sure.
And pain control?
Yes. So the primary use of opioids are to control what will be moderate to severe pain. And they work not only in the periphery, but they also work in the central areas of the brain. And unfortunately, the great side effect from opioids is respiratory depression. But before you get to respiratory depression, it actually does decrease people's level of awareness, and that's an effect across multiple areas within the brain. So awareness, inattentiveness, just depression from the environment, and I don't mean the psychiatric mode depression, just the ability to interact with the environment. And then finally, the relief of pain, and then you get to the point where you can have apnea occur. So the opioids have to be titrated carefully, and again, if it's an ultra short-acting opioid, as we currently have, so during the operating room we can use it as an infusion, but the pain doesn't know it's supposed to go away just because we're waking the patient up. So because of that, we still need longer-acting opioids, either to be given intravenously or orally, so that the patient can have good pain control during the peri-operative inflammatory phase for the next 2 to 5 days or even longer.
Gotcha. Thank you. I think, Dr. Tobin, we've now hit, I think, each of the questions that have been asked, in a very positive way. We've gotten just a handful more comments. One says, awesome presentation, so thought-provoking for interdisciplinary collaboration. Another one says, great seminar, very informative. I'd love to take credit for those comments, but I can't. Those are all aimed at yourself, Dr. Tobin, so thank you very, very much for your discussion today. Is there anything, Dr. Tobin, in closing that you wanted to share with the audience? I think we've got your information. We want to thank Medtronic for their sponsorship of this, and they're putting you in front of the audience. I know literally 90% of the audience stayed on, 95% stayed on almost for the entire presentation, and then we lost a couple in Q&A, but it's a sign that you were well received by the audience, so thank you very much.
Well, thank you, Scott. I guess as my parting message, it would be that since this presentation was specifically put together for people in the C-suite, where I didn't expect a great deal of facility with either our terms or with this product, or even the day-to-day challenges with anesthesia. But my pitch really is this, that although we may send a directive to a chief of surgery to reduce infections, or to a chief of anesthesia to say reduce awareness or reduce postoperative delirium, these upper-level managers or leaders still require the backing of the C-suite, both in financial resources as well as commitment to patient safety. And when we don't see that happen, or it's not highly visible, we wind up seeing systems that break down and don't do as well at penetrating the root causes of problems that we really can reduce medical errors and other issues that affect patient safety. So thanks to everybody in the C-suite, and that includes the CEOs, the CFOs, the chief nursing officers, chief operating officers, because without you, we can't make the difference that we want to make on a system-wide basis.
Thank you very much. I'm going to ask you one quick question again. What's the percentage of patients? How often do you see this? Just to give us some sense of it. Is this 1 out of every 200 patients, 1 out of every 100 patients? What's the extent to this?
Well, it's substantially greater than that. So if I take just the Medicare population, of which is a growing percentage of who we care for every day, we still see postoperative delirium somewhere in the 15 to 25% range. And the reason it's not higher is that although patients may be that elderly, they're not all having as major surgery as the types that I've described here. So not everyone is having a AAA repair. But we still see it significantly, particularly in our inpatient population. But we've had unfortunate needs to have to admit patients because we thought they would be fine when they woke from anesthesia and could go home, but they really are not fine, and they need a monitored bed for nursing safety. So it can happen to anyone, but I really think it's more the Medicare population at risk, and then anyone with a pre-existing neurologic condition.
Got it. So it's really for the population above 65, any kind of significant amount of surgery, more significant surgery, higher acuity surgery, more substantial surgery, more along the lines of 15-20% plus versus a small percent.
Yes, I'd agree. So if you compare that with the patients that come in for cataract surgery or other types of retinal detachment surgery, really not nearly the physiologic stress that major surgery such as cancer surgery or orthopedic surgery or cardiac surgery is. And so that's why we've now begun to believe it's no longer just anesthetic and blood pressure management. It really has to do with surgical inflammatory markers, which we see go quite higher when there's been more trauma because of more major surgery.
Got it. Very helpful, Dr. Tobin. Thank you very much. I didn't mean to reintroduce the discussion, but thought it was helpful to just get a better sense of the extent of patients. That's extremely helpful and interesting. Thank you so much again.
Scott, thank you to you and your group. This has been a pleasure to prepare for this and have an opportunity to interact with thought leaders and those who can make this happen. I very much appreciate a chance to get that message out.
Thank you, sir. Emma, we'll go to you and cut out, but I want to thank our audience, Medtronic and Dr. Tobin. Just a fabulous presentation. We appreciate our audience joining so much. Thank you, folks.
Thanks so much. Scott. Have a wonderful rest of your week. Have a wonderful rest of your